buttons that I need to be not pressing. Okay, got it. Okay.
You
Hello.
are fine. I feel like the start of these are always accurate because everyone's like getting on and it's like starting.
Yeah.
And it
Yeah.
tells your followers you're live. So I just said that we're going to start talking about PCOS and the effects it has on the body and also what it means for your future fertility.
Yeah. Sounds good.
And if anybody has any questions, feel free to just submit them as we go along. We also have a live that we did last year about like what is PCOS in more detail about like diagnostics. So we will link that below too once we're done. All right. Do you want to start us off, Dr. Thakore?
Yeah. Yeah. So I think, today we really wanted to focus on and not just like how to diagnose but PCOS, but we've been getting lots of questions about what what are the inner workings of PCOS? What is it doing to your body? How does your body change because of it? Or what are the different things that potentially contributed to it, right? So, I like to, just in brief summary, I like to think of PCOS as it's a hormone imbalance. It means that things are just not communicating properly in the brain. And there's different things that can interrupt that communication. You just don't know, for some person it may be testosterone, another person it may be insulin, and they all have a role to play in just how hormones work. They don't just affect one part of the body, they affect the whole body, right? So just because the hormone is based in the reproductive system, it doesn't mean that it's not going to affect other things outside of that too, because it's getting to every part, every corner of your body. Okay. So I like to think of PCOS as, like I said, that miscommunication between the brain and the ovary. In the reproductive world, what that manifests as is irregular ovulation or a lack of ovulation, and then therefore irregular periods because the brain, the uterus, the ovaries, they're just not cooperating. Okay. And the big hormones that we talk about as potential reasons for that lack of communication or interruption of that communication, we talk about testosterone, we talk about estrogen levels, and we talk about insulin levels. Those are biggies that we talk about.
All right. So can you explain what PCOS like does to the body?
Yes. And so, these hormones, like we just mentioned, that I just mentioned, they are more likely to cause havoc in the normal control of the reproductive system, but they also can expose other areas to not so great side effects as well. So let's talk about testosterone, right? How does testosterone affect the body? Well, women are supposed to create testosterone. You're supposed to have that in the body, and there's different precursors that are also supposed to be there. But the body is supposed to have just an average amount. And now when you ask me what that average amount is, I'm not going to be able to give you an exact number because it really depends on where you got your blood tested and the test that was used and what those parameters are. So I could give you a number of 60, 70, 80, but it could really depend on what your body or what that lab's upper limit of normal is. So I can't really give you an exact number. But elevated testosterone levels outside of where we would expect them to be in the normal female now incite hormone receptors in different places that are not usually active. So now you're looking at hair follicles, you're looking at sweat glands, you're looking at things that then cause acne, hair loss on the top of your head, these different type of symptoms. That's how testosterone's going to affect your body outside of the lack of ovulation that you may see with elevated testosterone levels. Okay. Now, if you talk about insulin, how is insulin going to affect the body, right? Insulin is a hormone that is created every time you eat something, every time you have calorie intake, every time you put something in your body to eat or drink, that then causes the insulin levels to rise. However, if your body's constantly seeing calorie intake or multiple times throughout the day in large amounts, then you see this, it doesn't have a chance to reset and go back down to zero. So you're getting a little spike and then you get another spike and then you get another spike, and the fasting levels just continue to rise. When your fasting level insulin rises, that's basically telling your body, hey, I need these calories. I need whatever you're taking in. Don't get rid of it. So elevated fasting insulin levels are telling your body, store, store, store. So no matter how hard you work out, no matter how hard you try to change the weight loss protocol of what's going on, it's not going to work because you're basically fighting a system that's then telling your body, I don't care how hard you work out, I still need these calories, right? So that's insulin, and that's how insulin can affect your body, right? And then we know PCOS has many different versions, right? You've got your classical PCOS for people who are maybe a little bit more overweight, and you've got your thinner PCOS, which is what we call lean PCOS. They all still have these manifestations of elevated insulin levels, elevated testosterone levels. But in classical PCOS, you also see an elevation of estrogen that can also cause problems as well. That elevated estrogen doesn't come from the ovaries, because the ovaries are quiet. They're not producing an egg like we expect them to. That extra estrogen is actually coming from the body fat. Body fat makes estrogen. It converts testosterone to estrogen. So if you got extra estrogen and it coming from other places outside of the ovary, then the ovary thinks, well, I don't need to make estrogen because it's coming from other places. And so then you don't get that typical egg production and that normal conversation that you expect to see for ovulation. So that's kind of how these hormones affect the body outside of the reproductive system.
Do patients who have PCOS always have like insulin resistance or no?
So they don't know. And that's the thing, is every PCOS patient could theoretically be different. Just because you have PCOS doesn't mean that you're insulin resistant. And just because you're insulin resistant doesn't mean you have PCOS. They are not the same thing. They're two separate things that can run in parallel in the world of PCOS. Okay. Elevated insulin levels also, in its own secret way, affects androgen production, affects testosterone production, affects testosterone receptors. So you can have elevated testosterone, and you can have side effects of having elevated testosterone in somebody who's insulin resistant that doesn't have PCOS either. So that's the reason it's so confusing, is because there's so many different things and they all kind of merge into one. But just because you have one doesn't exactly mean you have the other. That's why we need to meet all of that the diagnostic criteria that we had talked about before, to really truly say, yeah, you got PCOS, not you got insulin resistance and it's making similar symptoms to PCOS.
Yes, I think we had like a question is, I have PCOS and insulin resistance. Is that the reason I'm not getting pregnant?
Yeah. And you can, I think that's a loaded question, because
Mm-hmm.
yes, we know that insulin levels, elevated insulin levels, can inhibit ovulation. But even if you fix those insulin levels, there may still be something happening on the PCOS side of the world, like testosterone or estrogen, that may also be inhibiting that conversation. So the goal when you're managing PCOS is like with all these different facets, like, insulin resistance and elevated testosterone levels, right? The goal is to manage all of it together at the same time. If you can manage all of it together at the same time, you're giving yourself a better chance at being successful to conceive.
Okay. I think that we had like some questions about my insulin resistance. Is it because I have PCOS, and is that like the reason that I'm not getting pregnant? And like, what can I
Yeah.
do?
So if insulin resistance is affecting your ability to get pregnant, specifically your ability to ovulate, because that's the only thing it's really going to impact in the reproductive world. Okay. So if you're asking, does insulin have an impact in that? It can. The management to that would be doing either diet or exercise routines to help lower your fasting insulin, so it's less likely to be a concern and a block on ovulation, or use different supplements or medications that are known to lower those insulin levels by making your body more sensitive to it. So if your body's more sensitive to it, then it doesn't need as much to then create the outcome that is ideally wanted, right? So what are insulin sensitizers? The only medication that we have on the market that's FDA approved as a true insulin sensitizer medication is metformin, right? And honestly, that's why when people have PCOS, your GYN may throw metformin at you, whether you're insulin resistant or not, because the theory is that PCOS is associated with insulin resistance. However, if you do testing and you show you don't have insulin resistance, that metformin is not going to work for that particular PCOS person. Okay. But the way that metformin works is it helps lower those insulin levels. And by lowering those insulin levels, removing that block on ovulation, therefore making it more likely for your natural cycle to work normally, so then you can achieve a pregnancy, right? So if we're treating just that aspect of it, or insulin resistance outside of PCOS, metformin can play a part to play, or have a part to play, okay? Metformin has horrible side effects. Everybody will talk
Yeah,
about it. I'm sure you heard it in multiple different places.
about like metformin's giving me like GI issues, metformin's like making me not sleep. Like, what else can I do? Or is that like
So
the best option for me, like in this situation?
yes, and so like we were talking about insulin, like metformin, just it's one of the only medications we have for insulin sensitivity. Unfortunately, that's what we need it for.
Mm-hmm.
Um, the only other way to kind of get around it, one of the supplements that I like is myo-inositol. Myo-inositol has been shown, and it comes in lots of different brand names. It can come in a pill, it can come in a powder. Honestly, there isn't really great data of what dose you should be taking. So whatever supplement brand you buy, read the label, take what the label says. That's what I say. Okay. But that being said, myo-inositol is a dietary supplement. It's a medication that you can, like a supplement that you can take, not a medication you get over the counter, but has similar effects to insulin as metformin does, and is usually tolerated a lot better. Now, it doesn't work as strongly as metformin does, so you're not going to see as great of a benefit as if you were taking metformin, but you may see some benefit versus no benefit for taking nothing. So that's the other alternative I would recommend considering is myo-inositol. Okay. The other alternative is naturally trying to lower those insulin levels, like we talked about with diet and exercise. Hard to do because PCOS, like we talked about in the past, PCOS is very resistant to weight loss. Like it just, your hormones don't help you with it. It's like you're fighting your body, and we get that. I completely get that. So you need to do things that will hopefully help with that lowering of that fasting insulin level. If you look at diets, and we can go into this a little later if we have time, but the one that I recommend is intermittent fasting. It's not really a diet. It doesn't matter what you eat. Ideally, through this intermittent fasting, you will have some calorie restriction because you're just going to have less time to eat everything in. But it doesn't really require any rules or regulations other than allowing your body to not have any calorie intake for an extended period of time, allowing those fasting insulin levels to come back down to normal rather than constantly having those spikes that then just build on top of each other. Okay, so I would look into that as well
I,
if that's something you're looking for.
yes, I think we had a question. What test do you get to see if you are insulin resistant?
So there's a few different ways to test for insulin resistance. The gold standard is to do a sugar test. If you've ever been pregnant before, you've done a version like this to check for diabetes. Okay, so you would drink this really concentrated sugary drink, which tastes kind of like flat soda, in my opinion.
Yeah.
You guzzle that down, and then you take blood tests, like at the time that you first drink it, or right before you drink it, and then an hour or two later. And that will then, if depending on what those results are, they then will then indicate that you're insulin resistant. Sometimes you can get a fasting. I like to just go directly to the insulin, so I get fasting insulin levels. Again, this is not a good way of truly diagnosing it, but
Mm-hmm.
it's a quick and easy way for me. If you've been fasting for 8 to 9 hours, get an insulin level first thing in the morning. That will then kind of tell me, well, you shouldn't have been eating all night. And if your insulin levels are still really high first thing in the morning, that tells me that you've got insulin resistance, right? So there's lots of different indirect ways of assessing it. Another way to potentially at least get an idea of if that might be an issue is to get your hemoglobin A1C, which is your average sugar level over the last few months. But again, the actual true way to diagnose it would be a glucose tolerance test.
Okay. And can you get that like at your primary care?
You can. You can get that with your primary care. Typically, sometimes your GYN will evaluate it too. An REI can do it for you as well, endocrinologists. These are all different places that you can get this testing depending on who you're already kind of established with.
Okay. And then what do you recommend first for someone who has PCOS and hypothyroidism in the fertility clinic?
So, I think it depends on what the other testing would be. So now referring back to kind of our fertility 101, like
Mm-hmm.
Instagram live that we did a little while ago, right? There's a lot of evaluation that you want to do. Just because you have PCOS doesn't mean that's the only reason that's preventing you from getting pregnant, right? We know that there potentially could be other underlying things. So I would always say if you've been trying for 6 to 12 months to get pregnant, maybe at least getting that initial evaluation and establishing either with a fertility clinic or at least with your GYN to get the basic evaluation would be appropriate to make sure you're not missing anything else. Now, if PCOS is the only reason, then the question is are you ovulating or not, right? Because if you're ovulating, then the one big thing that PCOS would do to the system isn't really affecting anything too much, to the point that it's not preventing you from getting pregnant. Okay. But if you're not ovulating, then usually the first line therapy is using a little bit of fertility medicine like letrozole or Clomid. Studies do show that letrozole is a little better. So letrozole is brand name for Mara. So letrozole is a little better at helping with pregnancy rates in PCOS specifically. So that's usually why that will get started first. But Clomid can do similar things as well and pretty good at still helping with pregnancy. It can maybe override that ovulation inhibition a little bit and really kind of help you ovulate on a more predictable manner to be able to then achieve a pregnancy more predictably. Now, when it comes to thyroid and hypothyroidism, that's like its own little category. It doesn't usually mix with PCOS. Those are two separate things, but that's an abnormal function of the thyroid gland, right? So if your thyroid's not working as well, it can also manifest, especially in the severe hypothyroidism range, as affecting your ovulation as well, but more at the brain level than at the ovary level. Okay. So in that scenario, managing the thyroid and getting it into a normal range for a normal reproductive age woman would be the appropriate management. So that would be a different medicine.
All right. So we had a lot of questions about like, I have PCOS, I have irregular periods. What can I do to get like a regular period so that I can conceive?
Yes. And so that honestly, if somebody can figure that out, we're going to make millions of dollars. Come find me. We'll set something up. But that being said, unfortunately, if you can't override the body with some natural, easy means, you have to use medications to override it. PCOS in and of itself is an intrinsic process. It's internalized, it's within your body. We don't know chicken or the egg. Is it the ovary that causes the PCOS, or is it the body environment that then causes PCOS? We don't know what it is, but they all interact, right? So the first step, if you're trying to do this as naturally as possible, if you're trying to get your periods more regularly as naturally as possible, would be to, add some of those dietary supplements like the myo-inositol, that way then you're maybe managing if the insulin is a part and parcel to play in this. Diet, exercise, if weight is an issue, reducing that weight seems to help. We have studies that document and say if you're overweight, losing 5% of your body mass sometimes tricks your body into ovulating more regularly because those hormones are now better controlled, right? But that's not an easy option for everyone, right? And so that's something to keep in mind. If you're trying to do this naturally, the first thing would be diet, exercise, and adding some dietary supplements and see if that works. But if it doesn't work after 2 to 3 months of trying that, it's unlikely that it'll work 6 months from now. Okay, so don't just assume that that's going to be the solution, because it might not be, and you may need some medical intervention to help you.
I think that we had a bunch of questions about not having a regular period and like what to do. What if a patient is older and doesn't have time? Like, what are their options?
Typically, I'd say if you're on the older side of things, if you don't have regular periods, whether it be with PCOS or due to another reason why you're not having regular periods, you want to seek help sooner rather than later, because it's really important for us to get that evaluation done and start using interventions, because unfortunately, the older we get, age will also have an impact. I say the one thing that PCOS is good for is that people with PCOS have higher egg reserve levels. Those ovaries are chock full of eggs. They're kind of in there for some reason. Either you were born with extra eggs, or they just aren't getting rid of the eggs as fast as some other people that don't have PCOS. We don't really know what that is, but it's one of those theories, right? But because you have all of those eggs, that's fantastic. That means you're not going to run out of eggs as soon as somebody else in your age group that doesn't have PCOS. However, the quality of those eggs will still decline. Just because you have a good quantity of eggs does not mean that the quality is not being affected as we age. So just because we think we've got lots of eggs and we've got time, that doesn't correlate. You really need to be able to have that little buffer of just, let's get some help, let's keep moving based on age, with or without PCOS.
Hold on real quick. We had a question about, I'm a patient at your clinic. Is the insulin resistance test something I can ask the nurses about, or should I go to my OBGYN?
No, you can always ask us if you're a patient at one of our clinics with one of our physicians. You can always call the nurses, and they'll touch it. Whether you're one of my patients or you're one of the other physicians' patients, if that's something you want to have evaluated, just let the nurses know, and they'll touch base with your physician and just get that approval to do it. But we can definitely run that through us.
I just wanted to get to that question because they were asking something specific about us. What does a patient with PCOS, how does it affect their egg quality? Like, what is it doing to their eggs?
So PCOS doesn't directly affect the egg quality. So that's good to know, because just because your hormones are out of whack and the eggs aren't coming out the way that they're supposed to and they're bunching up within the ovary, it theoretically still does not impact the quality of the eggs. In patients that do IVF, for example, okay, um, whether they're PCOS patients or not, the egg quality is then correlates more with the age that that person is, not if they have PCOS or not. So one of the benefits with PCOS is if you did happen to do IVF, for example, you're going to get more eggs. If you get more eggs, you're going to then eventually have more embryos. Therefore, you have a more likelihood of being able to find a good embryo to be able to use to achieve a pregnancy. So that's a benefit, right? But it doesn't impact the quality of the egg itself.
Okay. Do patients with PCOS have a higher AMH level, and does that have anything to do with trying to conceive?
Yeah, no, that's a perfect segue. So like we just talked about, ovaries and PCOS, chock full of eggs, right? AMH is the hormone, anti-Mullerian hormone, is the hormone that is made by all of those little eggs that are sitting around waiting to do something. So the more little eggs you have stuck in your ovaries, the higher your AMH is going to be. So the AMH is not a reason for PCOS. The AMH is an indirect measure of the fact that you've got all those eggs sitting around because of PCOS. And then that's why your AMH is high. So in certain populations, specifically our pediatric population, where you don't really want to stick a vaginal ultrasound in them because they haven't had intercourse yet, they haven't even had a pap smear yet, that's in order to diagnose those ovaries, sometimes you can't see it with an abdominal ultrasound. Some providers are using AMH as an indirect measure of PCOS on an ultrasound to be able to then say, yeah, this patient most likely has PCOS, but I'm not going to subject them to an invasive ultrasound because they're too young or maybe they're not ready yet, right? So we use AMH as an indirect measure of how many eggs may be within the ovary, and it's a indirect correlation to what they may look like on the ultrasound. It's not diagnostic of PCOS, okay? So you can't use AMH, and a high AMH then means you have PCOS. It correlates. A high AMH is typically seen in PCOS, but it's not always the case, okay? And it's not, AMH is not a result of PCOS per se. It's not a bad thing.
Mm-hmm. I think people think they have like a high AMH, and that means that they'll conceive easier. What can you like explain what AMH is and how it plays a role in fertility?
Yeah. So, like I said, AMH itself is a hormone that's an indirect measure of how many eggs that you have within the ovaries. So, just because we have a lot of eggs within the ovary doesn't mean it's going to be easy to conceive. The exact opposite is the same as well. Just because you have a very low AMH and you don't have very many eggs in the ovaries doesn't mean that you won't be able to get pregnant. Okay? So, what we know is just the AMH, all it tells us is how many eggs are there. It doesn't tell us how the eggs are functioning. It doesn't tell us the quality of the egg. It doesn't tell us if it's going to produce a successful pregnancy or not. All it tells us is the quantity. How many eggs are there and how can we manipulate that quantity to be in our benefit? Okay, so high AMH is reassuring because that means we've got time, okay, in regards to a few years from now, you're not going to be hitting menopause anytime soon. But it still doesn't have any indication on the quality of those eggs, what the genetic abnormality rates are going to be, what your success rates for pregnancy, if you're going to ovulate on your own, because you need to do that to be able to naturally conceive. Like the AMH doesn't correlate with any of that.
And then, what are some fertility risks? I know you just said a bunch of them, that patients with PCOS may have. I think one of them was they were concerned about like hyperstimulation and like what can you do to lower your risk?
Yeah. So, PCOS PCOS is definitively a spectrum.
Mm-hmm.
There's the really mild PCOS that you just need a little bit of medicine to tweak the process and then everything goes perfectly fine, right? And then you've got the really, really, really resistant PCOS that, like, no matter what we do, we just can't get that ovary to turn on, right? And there's every version in between. So if I always tell my patients, if you're on the easier side of PCOS, meaning we can give you a little bit of medication and we're seeing that egg grow and ovulate and doing what we need it to do successfully, then we've overcome we've overcome anything that PCOS would potentially be causing a problem for. Okay. And we should be able to achieve a pregnancy. And if not, then there's something else going on that we're not correcting for that's outside of PCOS. Now, there's certain patients that are super resistant, and we can use low dose letrozole, we can use Clomid, we can use injectable medications, we can do lots of different things, and those eggs just don't grow safely, right?
Mm-hmm.
Because then in that scenario, you're getting no eggs, and then all of a sudden you're getting 10 eggs. No one's in the business to create octomoms. We are not trying to make many, many, many babies all at once, right? And if you're going to ovulate 7, 8, 9 eggs, or even 3, 4, 5 eggs all at the same time, and then try timed intercourse at home or IUI, you're going to have multiples. If you have multiples, that's really bad for you. It's really bad for the babies. So if we cannot safely only create 1 or 2 eggs at a time, that's the type of PCOS that sometimes requires you to go to IVF. Because now in the IVF world, the number of pregnancies that we put back inside the uterus is then the number of babies we create, right? So you can create 20 eggs and we can create 7, 8 embryos, but we only put 1 back in. Now you only have 1, maybe if it splits 2, that's safe, right? So sometimes we go to IVF for these more aggressive treatment options in the fertility world to be able to make sure we have a good safety profile for future pregnancy.
Right. So we just talked about when is it time to go from like ovulation induction to potentially IVF. Does PCOS have any like problems with implantation? Does it lower your success rates? Like what is it doing to your chances of like achieving a healthy pregnancy?
Honestly, PCOS in and of itself, without looking at any of the other comorbidities, meaning the other things that come with PCOS due to elevated weight or obesity or sugar levels and diabetes and like all of that stuff, has its own negative impact on implantation. But PCOS in and of itself without those factors does not really change your ability to implant. It does not affect the embryo's ability to create a pregnancy within the uterus. So as long as we can create the home that the pregnancy needs, we should be successful at creating a pregnancy. The PCOS in and of itself doesn't affect implantation, okay? But we do know that obesity, so BMI over the age over 35, we know that it decreases implantation rates. We know diabetes increases the risk of miscarriage and birth defects. We know that all of these other things that come with PCOS, high blood pressure, heart disease, cholesterol issues, diabetes, all of insulin resistance, all of those things can negatively impact the pregnancy itself, increasing the risk of high blood pressure during pregnancy, increasing the risk of gestational diabetes during pregnancy, increasing the risk of complications once you are pregnant going through pregnancy, right? So those are things to consider too. Hyperstimulation in and of itself, so that was one of the things that I forgot to mention in
Yeah.
the last question that you asked. So that's, if we do end up going down the IVF route, one of the biggest risks for PCOS patients, because they've got so many eggs just sitting there waiting to do something, they can hyperstimulate, basically meaning that they're creating so many eggs and all growing together at the same time that their body doesn't know what to do with all those hormones and all the extra prostaglandins and VEGF and everything else that comes with the creation of those eggs. In that particular scenario, in a hyperstimulated state, we do know that fresh embryo transfers have decreased implantation rates. Okay, so if you're hyperstimulated, then in that scenario, you really wouldn't want to put an embryo in. But that's transient. Once all those hormones resolve, once everything kind of goes away, the ovaries go back to normal, the uterus kind of goes back to normal, then implantation rates are pretty equivalent on par with everybody else. That's not affecting it. It's just at the time of hyperstimulation that you see those negative pregnancy, that impact on pregnancy and implantation.
So you would do like a frozen embryo transfer
Yeah,
then?
So typically in those scenarios, if we have a PCOS patient going through IVF and they've hyperstimulated, we will then not recommend a fresh transfer. We will recommend, even if they're not needing to freeze it due to biopsying the embryo or something like that, we still will recommend that we don't put an embryo in right away. We let the body resolve and recover, and then we put an embryo in as a frozen embryo down the road.
We have a question. Can low progesterone due to PCOS and not ovulating regularly affect successful implantation?
So the low progesterone rates, or sorry, low progesterone levels are directly due to the fact that you're not ovulating. Okay, so if you have low progesterone levels, that means you're having not great ovulation or you're having no ovulation. So that's how that links in with PCOS, because with PCOS, if you're not ovulating, you're not going to have great progesterone levels. If we can overcome that, and if we can get you to ovulate, your progesterone levels should be more than adequate to help achieve a pregnancy and maintain a pregnancy.
Can you overstimulate from doing like letrozole or any? Okay.
Yes, not in the order of making 20 eggs.
Yeah.
But I have seen people on letrozole and Clomid create 5, 6, 7 eggs. Again, not safe.
Mm-hmm.
We cancel those cycles. We don't take them through their full treatment. But you can overstimulate on oral medications. It's less likely. It's rare, but it can happen. I have seen it. You're more likely to get into that scenario when you're using injectable medications that are meant for IVF in IUI or timed intercourse cycles. Because again, you can't control how the body and how many eggs respond to those injectable medications. So you're basically fueling the fire in that, and that's where you go from 0 to 5 or 6 eggs all at once.
And then we have we had another question. Can PCOS be like cured or go into remission, or is this something that you will deal with your entire life?
So typically, PCOS doesn't go away. Okay. Again, it depends on what you think is the true cause of PCOS, and we don't really know, right? Is it genetic? If it's genetic, that will never go away. If it's the burden of eggs within the ovary is what causes the PCOS, and then there are abnormal hormone levels associated with that, you do see PCOS resolve as you get older. As you start naturally using up all of those eggs, you get into your 40s, of course, this is not when you're going to be trying to get pregnant, but now your body has used up those eggs. Now you're actually in the scenario where now you've gone from too many eggs to normal amount of eggs. And now your body's going to react normally, and then you're going to have all those less side effects. You're going to have less issues with PCOS because of that, because now your body's normalizing and getting into a more normal level. Okay, so can it go away? It depends on what the cause is. If it's insulin resistance and you don't manage the insulin resistance, that's never going to go away. If it's due to the adrenal gland or the ovary making excess testosterone, that may not go away potentially. So I always tell patients you can't cure PCOS. It's very unlikely for you to cure PCOS. PCOS is, we know, weight dependent. So if you are, and I can't tell you what weight that is, right? Because everybody's different. For somebody, it might be 300 pounds. For another person, maybe 150 pounds. But when you cross your own personal weight threshold, you start seeing manifestation of the PCOS symptoms. But if you get under whatever that threshold is, maybe you won't start seeing it anymore. It doesn't mean it won't come back if you get heavier again, but if you can maintain below what your threshold is, you may see improvement or remission of PCOS.
What about using like GLP-1s and PCOS? Will that help with symptoms and like potentially help them naturally conceive?
So it depends on if the weight factor is what's preventing them from ovulating on a regular basis, or is insulin levels preventing them from ovulating on a regular basis, right? I would be cautious in using a short-term amount of those medications just to lower your weight, because it will rebound back if you don't change lifestyle, if you don't change diet, if you don't change everything else in association with that medication. Then you're basically you're not creating that foundation to then maintain what you've lost. And that's for any medication, any weight loss regimen. If you don't create that established foundation of a routine that's going to provide you with a healthier lifestyle, no matter how these medications help you get to that point, they will bounce right back again. The weight will bounce back again. So I say, use it in caution. You may see some benefit because if you lose weight, you may see a return of ovulation. Return of ovulation means now you might be able to get pregnant. But you then have to create a lifestyle and a diet and a routine that will then help you maintain that, or it'll go right back to the way it was.
Could gaining the weight back make symptoms worse, like your PCOS symptoms worse?
I don't know if I can tell you that because I don't know if we have really great data yet on if it gets worse or not. But whatever that inhibition is, whatever is causing those symptoms, unfortunately, if weight is a part of that, the heavier you get, the worse it's going to get.
Okay. Can PCOS play a factor in repeated implantation failure and or miscarriage?
So PCOS in and of itself, no. Again, those extra comorbidities that come with it, obesity, diabetes, cholesterol issues, not having a very healthy lifestyle, all of those things that come hand in hand with PCOS sometimes, those can in fact affect your implantation and potentially miscarriage rates. But PCOS itself, just the actual hormonal abnormalities and the lack of ovulation, that doesn't have a negative impact on those things.
I think we have a lot of questions is PCOS doing anything to your uterus or is it just your ovaries?
PCOS indirectly could be doing something to your uterus, and that's due to people with PCOS that have high estrogen levels. Okay, so if you have high estrogen levels, then and you're not having regular periods to shed that lining, estrogen thickens the lining of the uterus. If you've got persistently elevated estrogen and you're not removing that lining from the uterus, it can increase your risk of abnormal cells that can then be precancerous. Okay, and that's then how it affects your uterus and your implantation. So if you've been diagnosed with endometrial cancer before and endometrial abnormalities due to persistently elevated estrogen levels, due to PCOS and elevated weight, then theoretically, yes, then you may have a negative impact on implantation and pregnancies and retention and that type of stuff. But it has to get it takes a lot to get to that point. So that's the reason why we say in PCOS, you don't want to be going without periods for 6 months. Like every 2-3 months you really want to be shedding that lining. So if something is building up, you're getting rid of it and allowing it to process so that it doesn't build up and then become bad down the road.
I think we're getting a lot of questions about using GLP-1s and Ozempic for PCOS, insulin resistance. Does it affect egg quality? And how is it impacting IVF?
So
Should
we
we?
really don't have great
Yeah.
data on that. So this stuff is so new. We don't really have anything. I can't quote you any studies to tell you for sure that's the case. Anecdotally, I can tell you it doesn't seem to be impacting egg quality. Egg quality still seems to be correlating with maternal age more than anything else.
I just don't think there's enough data to go ahead and say that anything to eggs or IVF, anything like that.
Yeah, no, I don't think, and that's the thing too, is a lot of practices as well. The only way to, so if you think about it now, putting my research hat on, right? Like if you think about how would you even study that, right? It would have to be in the world of IVF because you can't determine egg quality. And well, first of all, we can't measure egg quality. There's no way to truly measure it. So you would have to indirectly measure it by embryo quality, right? Which then could be impacted by the sperm that you're using to create that embryo. So it's not perfect, but you would have to test the embryos to see what the quality of the embryos are, therefore the genetics of that embryo. And then you would then have to backtrack, and those patients would have to have been on the GLP-1s. But theoretically, we have them stop GLP-1s a few months or a month before they even go through the IVF treatment. So it's really hard. You'd have to then have people on that medication through their IVF treatment, which not a lot of practices still want to see happen. So it would be hard to even get that data, and that's why I don't think it exists.
And they're so new, being marketed to weight loss as well, right?
Yeah, it's really, I think if you look at it, it's only been on the market for what, 2-3 years, maybe. and it's
Mhm.
only really been popular over the last 2. So, we just don't have the data yet to be able to pull that.
Yeah. All right. Any more questions? I will wait like a minute or two.
Yeah. And while we're waiting, let me summarize.
Yeah, go.
PCOS is not a death sentence. It does not mean you will never be able to get pregnant. Okay. I know back in the day, some older physicians may still say that. I hear it, but it's not true. Okay. PCOS affects your ability to get pregnant by preventing you from ovulating. If we can overcome that, and you ovulate pretty regularly, you should be able to get pregnant with PCOS. The caveat is you may need help getting there. Okay. So PCOS, you definitely can get pregnant, but you may need assistance to get there if you can't figure out how to make changes to ovulate more regularly on your own.
One quick question. If you have PCOS, should you be seeing a fertility specialist right away or should you wait?
It depends on how comfortable your GYN is managing you. Some GYNs are very comfortable starting at the basics and just doing at least a little bit of that fertility management. And if you're, again, on that milder side of PCOS, that might be all you need. And if
Mhm.
that's all you need and your GYN is comfortable doing it, great. You may not need to come and see us. Okay. However, if you've been doing that for a while and it's still not working, now there's a different reason why you're not getting pregnant. Now you have to come and see us. Okay. If your GYN is not comfortable or your PCP is not comfortable doing that basic initial monitoring and evaluation, then come see us. We'll take care of you. We'll take, like REIs, this is what we do day in and day out. We deal with PCOS all the time. We know how to get around it. So we can then help guide you through that.
All right. Perfect. Well, thank you, Dr. Thakore, so much. This was a great live talk about PCOS, and
Perfect.
we will talk to you guys later.
All right. Thanks.
Bye.
Bye.